Everyone. Good morning, everyone. Thank you for joining today's webinar. We'll go ahead and get started. It's 10 o'clock Pacific now. So my name is Tiffany Chen, and I lead product marketing around our inpatient solutions. Now, length of stay, as we all know, is a significant challenge for many health systems. And this webinar is for hospital leaders who are looking to take steps towards tackling this challenging problem. Now, today we're really excited to share the perspectives and learnings we've gained through working with hospitals across the country on addressing patient flow. Now, before we dive in, just a quick note about logistics. You can submit questions throughout the webinar by clicking the Q&A button on the bottom of your screen. We have time allocated at the end of our presentation to answer them. And also, we will be sharing a recording of this webinar afterwards. So now that we have these housekeeping items covered, let's go ahead and dive in. Today, I am joined by our clinical operations experts, Marsha McCorder and Rahul Agarwal. Marsha is the Qventus inpatient lead for clinical operations, where she works with hospital partners to customize best practice processes for patient flow. She brings over 30 years of experience as a clinician, hospital leader, and healthcare consultant. She spent 10 years as the chief nursing officer of a regional community hospital, where she helped to transform the hospital's quality, regulatory, and financial performance. She has a Lean Six Sigma Black Belt and is a board-certified nurse informaticist. Rahul heads the Qventus clinical operations team, which is the professional services team that takes care of implementation, process design, and change management for deployments. He is a family medicine physician by training and spent over a decade as a hospital executive at CHI Mercy Medical Center, where he directed operations for multiple departments across professional and ancillary services. Now, for those of you who are not familiar with Qventus, we provide the healthcare industry's first closed-loop management system for intelligent operations. It is a comprehensive solution that includes 3 parts. First, an innovative AI-based technology platform that brings entirely new capabilities to the world of hospital operations. Second, predefined combinations of software and best practice processes that address specific issues. And third, expert professional services led by folks like Rahul and Marsha, who provide on-the-ground support for customizing and deploying Qventus solutions. The company was founded out of Stanford and McKinsey with a vision of transforming healthcare operations. We're a proven partner working with leading hospitals and health systems across the country to drive transformative results. Now, for this webinar, we will begin with Qventus's approach of transforming operations. We call this intelligent operations and how it is different from traditional methods for addressing length of stay. Then we'll walk through some of the key principles we've developed as we've helped our partners realize sustained length of stay reductions. And in this section, we'll also go through how to put these key principles in action. And we'll end by summarizing some key takeaways for successful transformation of length of stay operations. We'll have time for Q&A at the end, and if we're not able to get to your question during this time, we can follow up with you afterwards. So we have 3 objectives today. First, you'll learn about what is intelligent operations and its role in transforming length of stay. Then you'll discover key principles around optimizing length of stay and sustaining outcomes. And finally, how to combine technology and process to achieve results. So let's go ahead and dive into optimizing length of stay with intelligent operations. Now, today there are so many moving parts to getting a patient discharged. One of our partner hospitals found that it took them 279 manual steps. Now, most places have some form of a patient list that everyone rounds around, but the effectiveness of the round itself is highly dependent on the quality of the case manager. And rounds after rounds, case managers spend hours chasing barriers to get the patients discharged. And leadership, they only realize something is going wrong when discharge has already been delayed. And oftentimes there's no real understanding of what the underlying process issues are. Now, given the importance of length of stay, there's really been no lack of trying. People have been using tools like paper and EMR dashboards, but paper is very manual and it silos information on pieces of paper. EMR dashboards, they surface too much information and it becomes really hard to tell what actually needs to be prioritized. Some people, they use GMLOS to guide length of stay, but it is by definition an average across populations and has limited predictive value for individual patients. Now, people have also tried addressing this with process initiatives, but those rely on really superhuman efforts of our people to drive consistency. Multidisciplinary rounds are so variable when it comes to who is in the room, what people choose to discuss, etc. And lean projects, they have focused on ancillary coordination, but communication is so fragmented and manual that it's really hard to hardwire these processes. And the way leadership holds teams accountable for things like rounds is by occasionally dropping in or having somebody manually audit what is being discussed. And that's just not practical or difficult to sustain. This is why performance improvement projects, they often deliver initial results, but when the people change or attention shifts, it becomes a game of whack-a-mole where the processes revert back to the way they were before. Now, the good news is that it doesn't have to be this way. Outside of healthcare, we've entered the age of intelligence. New innovations are fundamentally changing other industries. There's artificial intelligence, which is impacting nearly every industry. There are advancements in behavioral psychology, so how to delight users and drive habit formation, and it's keeping us glued to social media and other apps. And there's data science, so using statistical analysis to understand which parts of a business or process are working well and which are not, and this way to really drive continuous improvement. These same innovations can be applied to healthcare operations. When you combine these innovations, you get a type of software solution that's simply never been available before, a category we call intelligent operations for healthcare. This is a comprehensive closed-loop management system that transforms your operations. There are three main parts. First, you can identify issues, not just retrospectively, but also now in real time and in the future before they occur. This requires real-time integration with your EMR and other systems, analytics, AI and machine learning for real-time identification and prediction, and situational awareness capabilities. But identifying issues alone isn't enough. You also need to orchestrate actions among frontline teams and ancillaries to make it easy for them to take the right action. This incorporates habit formation principles like nudges and rewards, as well as prioritized task lists, real-time collaboration with other departments, last-mile integration, and in some cases, complete system-level automation of key steps. You need to then close the loop and hold teams accountable. You can understand whether you're identifying the right issues and whether teams are actually taking the appropriate actions so that you can ensure continuous improvement. And this requires sophisticated data science and statistical outcomes analysis. And what we found after years of working with our partners is that no single one of these sets of capabilities is enough to drive and sustain change. You really need all three. When we apply intelligent operations to length of stay, our partners see statistically significant impact. And this impact is sustained or improved over the life of the partnership. As you can see across partners like New York Presbyterian, Emory, SCL Health, we've helped them achieve 0.3 to 0.7 day decreases in length of stay. These decreases have allowed our partners to create virtual capacity and achieve substantial savings. In the case of NYP, for example, the impact of length of stay initiatives has been equivalent to having an extra 35-bed unit. And these are beds they would have otherwise had to invest capital to build out. And SCL Health Lutheran Medical Center is on track to save $2 million annually from length of stay reductions. And it's not just about the patient flow impact, but also the change in behaviors and team culture. Our partners like Emory have noted a stronger sense of collaboration across the broader care team. And we also see high engagement and utilization of Qventus for capturing key information like estimated discharge dates. Now, in working with our partners and thought leaders in the industry on patient flow, we've developed our perspective around best practices and key learnings around addressing length of stay. I'll hand it over to Marcia now to walk us through our key principles.
Thanks, Tiff, and thanks everyone for joining us today. It's exciting to talk about what we've learned. Tiff just showed you our model for intelligent operations, and I like to think about that as the foundation for our intelligent operations in terms of people, process, and technology, terms we've all heard. As we all know, technology is just a tool, but for it to be successful, it has to be partnered with well-established processes and people who are really motivated to make the process work. Many of our clients have had enthusiastic staff and fairly robust processes, but no technology to support and guide the process. Their progress was stunted and their success was limited. Today, I'm going to talk about how the right tool can make a difference in improving and sustaining the length of stay reduction and how the people, process, and tools work together. As Tiff mentioned from our work at Qventus and our partners with clients, we have developed key principles for how best to approach addressing length of stay, and we've designed our technology and processes around these principles. The first principle is around proactively planning for discharge. Since the dawn of time, we've said discharge planning starts upon admission. So the goal should be to develop a discharge plan as early as possible in the patient's stay. This means not only focusing on getting the patient clinically ready for planned discharge, but also identifying appropriate disposition and aligning resources as early as possible. An agreed upon estimated date of discharge, or EDD, should be identified as early in the stay as possible, ideally within 24 hours of admission, in order to provide the team and ancillary departments a target to shoot for. It's understood that the EDD may change over the course of the patient's hospitalization, but most physicians that I have talked to agree that they can accurately predict discharge, a patient's discharge 48 hours out, at least 90% plus percent of the time. The discharge plan also needs to include identifying barriers, those internal and external factors that may affect care timelines or discharge by the EDD. Then the team needs to consistently work the plan. This means working to eliminate the barriers, escalating delays as necessary, and updating clinical readiness and EDD daily to reflect the care team's consensus and shared goal and keep everyone aligned on the target. Of critical importance is the team's ability to accurately predict the EDD 24 to 48 hours out. And the reason I say this is because that's when your avoidable days will happen if you're not managing the barriers. It allows for the barrier resolution that could lead to the avoidable days, and I kind of refer to that as the golden 48 hours before discharge. Especially when coordinating with ancillaries to prioritize patients and assign resources, we want to leverage technology to automate as many manual steps as possible and synchronize across the teams. This means reducing the number of manual coordination steps, such as phone calls, text, emails, sidebars in the hallway, and in doing so, reducing the cognitive burden for the care teams. Just one less thing they have to worry about. And finally, the part that many people miss is how do we hold teams accountable? Especially as leaders, you need to track variation from the intended workflows in real time, and that includes celebrating wins and escalating issues. You should be using the data to review performance, track outcomes, and optimize planning, and most importantly, sharing this with your teams. Let me show you how we apply these principles through process and technology. So why has length of stay reduction efforts proven so challenging? And the answer is because a tool that provides proactive intelligence, automated coordination and communication, and performance data has not been readily available or incorporated into the process. As Tiff mentioned, our length of stay solution focuses on hardwiring those proactive discharge planning and barrier coordination in a way that you can standardize and scale across all your units and multiple facilities. Let's look at these principles in action. We start with MDRs, where our intelligence analyzes thousands of data points in the background to proactively surface issues for the care team to address. Something that a person couldn't do. It takes the machine learning element. Qventus focuses on multidisciplinary discharge rounds primarily for our inpatient solution, and these can go by many different names such as interdisciplinary rounds, IDTs, MDRs, discharge rounds, etc. But no matter what you call it, it's a discharge-focused daily round for the care team to develop and execute against a shared plan for safe and timely discharge. These rounds need to happen on a daily basis, ideally mid-morning, and the most successful MDRs are comprised of the provider, case manager, and nursing. Representation from ancillary groups such as therapy, radiology, pharmacy, etc., can prove very beneficial, but it's understood that their availability may prevent them from attending regularly. We have orchestration mechanisms that I'll go over in a minute that show how we automate coordination with the ancillary groups even in their absence. The core information that these people that I just mentioned need to discuss for each patient during rounds are: first, clinical readiness. Is the patient clinically ready for discharge to the planned disposition? This is determined by the provider based on the patient's clinical status. The nurse and therapies often contribute to determining his status by contributing functional, nutritional, and mental status. Clinical readiness in Qventus is defined as yes, no, possibly today, and possibly tomorrow. By including possibly today and possibly tomorrow, we continue to communicate the team's best thinking and identify those patients for whom barrier resolution is paramount, and in times of a bed crunch, highlight the most likely patients to discharge. Typically, any hospital day beyond a patient being deemed clinically ready is counted as an avoidable day. Discharge disposition. Where will the patient go upon discharge? This is determined by the patient's post-discharge condition and status, social situations, and insurance plans. Barriers to discharge. These are any internal or external care or operational process steps that can delay clinical readiness or the expected or actual date of discharge. Barriers can be identified by anyone on the team, and we work with our clients to customize barriers based on their specific issues. Estimated date of discharge, or EDD. This one's really pivotal. The projected date when the patient is expected to be discharged based on that clinical readiness, where they're going, how well do they have to be discharged, and delays caused by internal or external barriers to discharge. The entire team weighs in on this projected date based on all of these factors. Accurate EDD documentation is really key to many of our other processes that we orchestrate. So if we don't get the EDD right, or at least right within the last 48 hours, it's going to have a negative impact on how well we can oil the wheels, if you will. The case manager plays a critical role in the MDR, serving as the conduit between both the internal and the external players, often coordinating placement and post-discharge services, as well as providing knowledge around reimbursement requirements, insurance plans, and so forth. The case manager is often the scribe during the rounds and documents within Pathfinder. MDRs proceed very quickly, we know this. Typically, the discussion should be no longer than a minute per patient. This fast pace requires having a strong case manager or a strong charge nurse leading the discussion to flag issues that need to be addressed and keeping the discussion discharge focused and moving. The leader needs to be sure that the 4 required elements are discussed and documented for each patient, and tomorrow's discharges are clearly identified. That's another key point, is making sure that you're always a day ahead of your discharges. Qventus uses technology to hardwire quality MDR discussions. Our intelligent MDR tool is a smart work list with embedded workflow for discharge-focused rounding. A unit-specific patient list is created from your EHR, and key discharge information such as length of stay and GMLOS are distilled in one place. The Pathfinder board is creating standard work that is visualized during the round so that the EDD, clinical readiness, disposition, and barriers are very clear, and everybody understands the shared plan and what needs to happen. There's embedded intelligence that flags potential discharge dates that need to be discussed. These flags are based on a number of factors such as admitting diagnosis, age, order profile, medications, etc., and suggest when the patient might be ready for discharge. They are conversation starters and don't rely solely on the case manager being comfortable challenging the physician to see if the team can be more aggressive with the discharge. So it kind of takes that onus of being the bad guy off of the case manager. Same thing goes with disposition. Qventus machine learning can suggest dispositions. This is really important because if the patient needs to go to a SNF, but perhaps the team or the group had said home with home health and you missed it, you could lose 3 days just waiting for that insurance authorization. So it's a good way to kind of do that background search and analysis of where the patient would be best suited to be discharged to. Finally, barriers to discharge. Instead of surfacing all open orders, Qventus looks for open procedure orders when the EDD or date of discharge is 48 hours out to identify potential barriers for the team to confirm. The teams can then focus on what activities are truly barriers. Our partners have described this as a night and day impact on their MDRs, saving care managers up to 30 minutes per day because of the automation and the removal of the manual coordination. So how do we fit this into standard work? Hardwiring that EDD, clinical readiness, disposition, and barriers as part of daily MDR conversation then makes it really clear what the standard work needs to follow. If the patient's EDD is today or tomorrow and they're on track clinically to be discharged, they have confirmed dispositions, no barriers, the teams can do the standard discharge work, which is such things as meds rec, transportation, DME, etc. If the patient's slated for discharge tomorrow and they have outstanding barriers, then we know that those barriers need to be prioritized for resolution to avoid delaying the discharge. For patients whose discharge is obviously further out, the teams need to just continue to work on that clinical treatment, determining the EDD and disposition and updating appropriately, and identifying and resolving barriers as they arise. So now most technology tools like EMR dashboards stop at MDRs. What they don't account for is that orchestration and accountability that follows. Let's dive into automating coordination with ancillaries for barriers so that they're in sync with the discharge plan. We talked about identifying barriers during MDRs, but even if you're able to consistently identify the barriers, then the problem is that the people walk out of the room without a clear understanding of who needs to do what and with what degree of urgency. There's also a lot of manual phone calls and coordination with ancillaries to get them resolved. And many times I've seen stat order priority misused in an attempt to have orders completed quicker. The stat overuse just compounds the issue and makes prioritizing work even harder for the ancillary departments. We believe that streamlining and automating barrier follow-up and coordination is crucial to making sure teams can safely discharge patients on time. When the care team confirms a barrier in Qventus during MDRs, it automatically triggers a coordination process with radiology, therapy, pharmacy, or any of the other ancillaries. Qventus adds that patient that's been identified with the barrier to a barrier work list for the appropriate ancillary department and automatically prioritize the patients based on machine learning. For urgent and stat requests such as same-day orders, Qventus can directly nudge the ancillaries through appropriate communication channels to prompt action. It's where you see on the right-hand side of the screen that looks like a cell phone. It's actually coming across, the nudge comes across as a text. This opens up a real-time virtual huddle for collaboration and takes away that multiple phone calling and manual back and forth with the care teams. We help you customize the coordination pathways. We see if the workflow is best suited for a prioritized work list or a nudge. Different clients have different preferences. Who are the people that actually have the power to take action on this information and participate in the nudge, etc. So it is a custom coordinated process. Our partners have seen a huge impact from this barrier orchestration workflows, particularly for radiology and therapy. For example, at one partner site, we incorporated behavioral science concepts into how we nudge physicians for outstanding MRI orders, asking them if the study could be conducted as an outpatient. And by doing so, 1 in 4 orders were actually converted to outpatient or canceled altogether. So again, we automated that communication and we saw a definite improvement. And looking at what are the top barriers to driving excess days, we looked across a sample of our hospitals to really figure out what were those drivers. And the barriers that are contributing to excess days can be split into internal or external barriers. Internal barriers involve other service lines like radiology or therapy, things that the hospital itself actually has control over. And external barriers, obviously coordination with external organizations, payer groups, post-acute care facilities, placement, social issues, those kind of things. From our analysis, we found that the top internal barriers are therapy, imaging, and echo. And what this means is it's really crucial to have tight coordination pathways with these ancillary departments to make sure that these barriers are consistently identified, resolved, and escalated as necessary. For external barriers, we found that placement, bed availability, insurance authorization, and transportation were the key drivers. It becomes critical to make sure these barriers are proactively identified during rounds and followed up on. In some cases, our hospital partners have used barrier information from MDRs to create coordination mechanisms with appropriate external partners. For example, we worked with a hospital who partnered to create a prioritized work list of patients with ambulance or other transportation barriers. This allowed them to better coordinate with EMS to partner to schedule rides for patients targeted for discharge before noon. With this type of analysis, we've had hospital partners take targeted actions to address top barriers driving up their own avoidable days. For example, making sure physicians take patients off isolation orders in a timely manner, or working with their payer rep to help prioritize patients facing insurance authorization issues. I'm going to hand it over now to Rahul to speak about our approach towards managing accountability, which is also one of the key gaps in most length of stay initiatives.
Thank you, Marcia. So let's move on to how leadership monitors process fidelity and holds teams accountable. So how do you keep this initiative from becoming a member of the Flavor of the Month Club when there's so much going on? Organizations routinely see processes fall apart when leadership, focus shifts to the next project. Now, you could, as leaders, drop in on rounds to make sure teams are having effective discussions, but it's really impossible to do that every day across several units. With Qventus, we help you track how effective you are at discharge planning during MDRs and managing barriers in real time. For example, do your care teams capture estimated discharge dates and dispositions during MDRs? Or, as you can see here, what are the top barriers that are backing up discharge? And how long is it taking to resolve barriers? Think of these as process vitals for your MDRs. Now, this is information that is otherwise lost on pieces of paper or through back and forth phone calls and messages and shared notes. So this approach opens up a whole new way of managing operations because you can course correct in the moment. One analogy would be a rocket launch. You can do a retrospective analysis for why it didn't go as planned, or you can correct the trajectory in real time when you notice that it's off course. Further, with intelligent operations, you can anticipate issues before they occur based on sensor data, spatial coordinates, or other variables, and make adjustments accordingly. If PT is backed up, you can pick up the phone and call them so that you proactively make sure that discharges don't get delayed. Now, what is also important is to set up escalation processes to make sure that operational leaders are looped in for key issues. With Qventus, we hardwire these escalation pathways to make sure the right operational managers are involved when we start detecting bottlenecks. For example, here we detect that there are a high number of patients where MRI is holding up discharge and then escalate through the appropriate communication mechanism to the head of radiology. This way, they are notified in real time and can intervene directly to see how they can help. And as you saw on a previous slide, barrier data is tracked and trended, so you can apply traditional PI approaches to improve processes or make infrastructure investments like more equipment or staffing over time to address these issues before they occur. So in thinking about this, what key performance indicators should you measure? Our framework is that you need to track behavioral or engagement metrics, process fidelity and process quality metrics, as well as traditional outcome metrics. So the behavioral or engagement and process metrics are leading indicators of how length of stay operations are going. So for MDRs, look at whether teams consistently discuss EDD, disposition, clinical readiness, and barriers. For orchestrating barrier resolution, you need to track if people are engaging with nudges, the barrier management work list, and how quickly and consistently barriers are being resolved. At Qventus, we also track metrics like how users respond to our AI-powered suggestions, like our smart barriers, so that we get feedback as to how useful those suggestions are. For outcome metrics, you should be tracking length of stay, and of course, related to that are excess days and avoidable days. But you also want to make sure you're moving towards safe discharges and not being so aggressive that you're affecting your readmission rates. As your teams get better with the MDRs, you can also track how accurate the EDDs and dispositions are. Again, this is where having a Qventus in place can give you visibility into EDD and disposition accuracy. I'll emphasize here that it's not just about holding teams accountable when things are going wrong, but also recognizing good performance and celebrating those wins. As a leader, I always felt like I wanted to do this every day, but there was really no easy mechanism to have the right inputs to share authentically with my teams when they were doing a really good job. So what we do is we automate analyses of process adherence, behavioral analytics, and discharge data to detect when your teams are achieving their goals. For example, this could be when units have established discharge plans for all of their patients admitted, or when units successfully completed all planned AM discharges. Now, this is one way we incorporate behavioral science to hardwire behaviors. It's a way for leadership to provide genuine, authentic feedback in a timely manner across many units. This also provides an opportunity to learn from high-performing teams and share these learnings and best practices with other teams. Now, when you have PI initiatives, you may find that your length of stay decreases during that time period. And this is typically done by comparing your LOS before and after the intervention. But it's hard to tease out if that's because of your initiative or other factors like case mix, flu season, volumes, etc. And that's where using statistical analyses to control for these patient, hospital, and seasonal variables is crucial to figure out how well your initiative is actually working. So beyond the technology and process work we just went through, we have data scientists on the team that help you evaluate the impact of your Qventus investment, or really any ongoing work you're conducting at the same time for that matter. This way, you can see how various interventions have affected length of stay in a statistically significant, meaningful way. So to look at the slide, for example, if we had a length of stay of 5.5 days prior to the intervention, and then saw it decrease to 4.7 days, it appears that the length of stay decreased by 0.8 days. But if we control for the changes in underlying patient mix and other operational variables, we see that the change is actually closer to 0.5 days. And this could be because the mix of patients we've seen more recently are not as sick as the ones before, or volume differences, or what have you. So I'll wrap up the presentation with a summary of takeaways that you can apply to your length of stay initiatives. First, accountability and buy-in are absolutely essential. It doesn't matter how solid your processes are. As a leader, if you don't emphasize the importance of the process and hold your teams accountable, things will fall apart. This means that management needs to enforce the consistent utilization of tools, celebrate successes early and often, and provide ongoing feedback. How well are we doing in capturing EDDs? Are we moving the needle on avoidable days? Are we hitting our length of stay goals? The key is that executive leadership needs to visibly prioritize the initiative. Physicians and nursing play a key role in MDRs, to state the obvious, so you need to make sure these stakeholders are on board and pulling with the team. The second lesson is that you need to be persistent. Change is hard, especially in the first 90 days, and you need to teach your staff not to change the process, even when things are slow or busier. Part of this is being very prescriptive of what people need to do and getting the details right. You need to have clear roles and responsibilities for MDRs communicated: who needs to be there, who is in charge of leading the discussion, what information does each person need to bring, and so on. And finally, true transformation needs to happen not just on the first pilot units, but across the organization. We actually like to think of the first units that go live as vanguard units versus pilot units. It just means you're going first, but everyone else is going to follow. And this may be obvious, but the benefits of automation become most apparent when it's scaled across the organization.
Thank you, Marcia and Rahul, for walking us through these learnings. So at this time, I'd like to open it up to questions from the audience. As a reminder, you can use the Q&A button to submit questions. All right, so looking at the questions, I'll take the first one and pose it to Marcia and Rahul. How should we align the organization and get buy-in from the different groups around like the STAY initiative? So people like physicians, nursing, etc.
I'll take a stab at that. I would say that leadership needs to really get out in front of any initiative and clearly articulate, like, why does it matter to the different groups? Length of stay typically seems like an esoteric, kind of financial outcome, but you need to translate it to better outcomes. I mean, if you're a patient, do you want to stay longer in the hospital than necessary? No. How does it make patient lives better? How can we serve our population by having capacity to take care of more sick patients? So actually getting to the why, I think, is really critical on, like I said, any initiative, but especially the length of stay. And then finding those internal champions, the frontline staff who are closest to the process, who understand the challenges better than others. Bring them into the discussion early on. They may initially be dissenters, but they're going to appreciate the fact that you recognize their knowledge of the challenges and of the process and brought them into the decision to make improvements. So I think those are two key things that have worked really well for me in the past.
Okay, thanks, Marcia. Then moving on to the next question, how does Qventus help us with the change management?
I can take that. So the short answer is that technology alone is never enough. You do need to focus on people and process. And we bring, quote unquote, on the ground experts to help you stand up your MDRs. And then we configure the workflows for each ancillary service and train your managers on how to use those tools to manage accountability. So for example, to help stand up your MDRs, our teams will help you train and support nursing or case managers on how to prepare for rounds, coach providers around what to bring to MDR. So the goal here is to focus on the discharge planning process versus having a long, detailed clinical discussion that is important to have, but doesn't necessarily mean the discharge plan forward. And then align teams on what a barrier is as a true problem to solve versus something to note, and how to ensure resolution. Develop workflows for AM discharges, and then coach teams on how to incorporate the Qventus tools, including our AI, to improve EDD estimation. And perhaps most importantly, we teach your management team on how to celebrate successes and consistently review the data and reports to make the necessary changes.
Okay. As a reminder, we do have the Q&A button, so feel free to submit additional questions. Okay, so at this time, we have a couple questions that it seems like might be things we follow up on. So we'll give folks some time back to your schedules. As a reminder, Marcia and Rahul, their contact information here is displayed here. And feel free to reach out if you have additional questions. We just had another question come up, and given the time, maybe we have some time to address this. So what baseline do you compare against?
That's sort of a general question. I'm going to make the assumption that you're asking what is the baseline length of stay we look at. And essentially, we pull data from the client for 3 years preceding the data deployment. And we look at what their baseline length of stay was for a year prior to implementation. When we make the adjustments for the statistical analyses, we'll typically look at the quarter leading up to the deployment. It just depends on how much good data we have and what the seasonal variation is likely to look
Okay, great. I think those are the questions. Again, some of the remaining questions will follow up, but I'll close out by saying thank you again for spending the time with us, and feel free to reach out to us if you'd like to learn more about what we've talked about today and how Qventus can help you with your patient flow initiatives. All right, thank you.
Very good. Thank you for your time.
Thanks, everyone.